Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Chandler, Arizona. For now, we are moving soon to Tempe, and I will keep updating people as that happens. But right now, I am in a hotel room in Scottsdale because that's the only place I could catch this guy. This is Dr. Paul Anderson. He's a dear friend and a leader in medicine. Very inspiring person in my life. And the reason why I wanted to have an interview with Paul, the first interview we do, is because the role he's played in influencing so many physicians, the way they practice, the way they approach medicine, and his style of medicine, and the way he views patients. Many of you have commented on Reels and sent messages and corresponded with us asking, why do we practice the way we do? Why is it that I approach patients the way I do? What was it that got me to practice medicine this way? Throughout all the episodes, you'll see I approach patients really differently from the way your traditional physician would. And I live in my own bubble, as I say, and I'm only used to practicing medicine in my world as I practice it. And I work with 7 other beautiful physicians who are inspiring people to me, and we all practice in a similar way. We don't know any other way to practice other than we do. So when people ask the question, it's almost like saying to a fish, how do you swim? It's just you swim. This is where you are. But that's not a good answer because I hear what you experience, and I get it. And I have patients that come into me from other clinics, and I see and I understand. There is a difference, and your question is valid, and it's on me to help you understand it. So I'm bringing in Paul, Dr. Paul Anderson. This is the reason why he's here, because this is how I began practicing medicine. This is the man that spent time with me as a med school student, helping me understand pathology, helping me understand human beings and how humans get well and humans get ill. He is the person that's helped me formulate protocols. He's the person that helped me understand how to formulate protocols. He is the person that has given me insights into how to practice medicine at a higher level, how to provide medical care at a level of care that is considered beyond normal. And I'm saying that because how we approach our care with our patients as the level of depth, the depth of lab work we do and the approach we do gives us so much information. And again, I would not have that foundation unless I spent time with this man. So Paul, you and I have spoken about your background, your history, your everything you've gotten to get to this point, and I've never really asked you. First, I want to say welcome to being my first person to do an interview with. I'm so thankful and I'm happy I got you here. I really am. Thank you.
I'm glad to be here. I am.
Yeah. So, What do you think of my question? What do you think? What are your thoughts on this? I've never asked you this question before. Yeah. How did you get like this?
Well, I'm sure my parents wondered how I got like that from the day I was born.
Yeah.
I think that it's sort of a collusion of 2 pathways, which are maybe multiple pathways. But the first thing I think that we should say out loud is there's a time and a place for the other way of looking at medicine, which is very brief algorithmic. So if you break your arm, the algorithm is set pretty much, unless something very bad happens. And you're going to get the same treatment. If you have strep throat, if you have whatever, those are not things that you need to really think outside the box for. You can go boom, 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 and if that algorithm needs a twist and a turn, it's already there. You're good. So the first thing is that I'm very familiar with that type of medicine. So it's sort of like that was the framework upon which I went to the next level to say, what happens when that algorithm just isn't going to work, okay? And you and I both have, similar types of patients, and the biggest frustration is even, their primary care specialist or whoever wants to help them, but because they kind of have to fit into these boxes of diagnosis and treatment care algorithms, they'll be just as frustrated as the patient sometimes. Not always, but sometimes. And so what I realized very quickly was, if someone came to me with a broken bone or strep throat or something, I could just do that. But most people who came to me, and then now all people, are like your patients, where they probably tried that and it didn't work. And either it could be a simple version of that, some of the, say, hormonal things, or things are just nobody looked and you fix it and it's all magical and better. Some things are, deeply layered chronic illnesses and all that. And of course, they're not going to fit into an algorithm very well either. So I just noticed early on, and the place it came from was, I just want to do the best thing I can for each patient. And each patient's very different. So if an algorithmic approach worked, wonderful, great. But that got to be less and less and less with chronically ill people with a lot of, especially in, the world of the hormonal therapies or toxicities, things like that overlap. There's not a straight line from here to you feeling better. And I remember a long time ago realizing that, I'd been taught some really good things. And as I said, I really knew that sort of allopathic background well, and it merged all this naturopathic information. But I realized as people started to come in, there's an awful lot I don't know. And rather than tell the patient that it's in their head, I thought maybe I should learn some things about that and, see where we could go. So that started there's this sort of forward virtuous cycle, I hope, of patient with something complex, something to help, and you learn some new things, and then they start to get better, and then the next person comes similar to them, but a little more twists and turns, and you realize, well, what made the difference with the first one? It was saying, what do and don't I know, and then what do I need to learn? And then you learn some more there. And, and then that led to people with problems I never thought I would see. And so you have to learn a lot more. And so some people, for reference, will ask me, 3 decades in, when is the last time a patient really stumped you? And I can honestly tell you it was this morning. And it's not that I couldn't help the person, but the need for the doctor to be continuously learning to kind of deal with this stuff is a huge piece of it. And so, then you and I met somewhere along 2004 or something, 2003.
You had a rib out.
That's a long time ago.
And I was a big guy walking down the hallway, and you said, "Hey, you're big enough." And you had me come adjust your rib.
That's right.
In a treatment room.
That's how we met.
Exactly.
My pain brought me to you. Yeah. I was like,
yeah.
He can probably do it. Yeah. Yeah. So 2003. Yeah. So that is 21 years ago, right?
Yeah.
So by the time, I was teaching where you were going to school, and I'd started, I'd been doing it long enough to synthesize some of this. Aside from constantly learning and all that stuff, then what happens is all that stuff that you learned, say, in year 1, 2, and 3, is now just sort of part of you. And you forget you didn't know it, like it was always there. Well, it wasn't, but, and then you build on that. So because in my own practice, and then doing a lot of teaching, it opens you up to, what other people are seeing too, and you have to explain it. The common thread was always take a step back, realize that some people don't need a lot of stuff. They just need, a few things. take a step back, though, and realize some people, it's multi-layered, and you have to really do some thinking, maybe learn some new things. So the thread between how do you deal with this person with all these things going on and this person with just a few things is, do I know enough? Is there something I need to learn or something I need to look up or, just make sure hasn't changed in the years since I've done it. And then the next level for that with our chronically ill people, where it's not so simple, is what does their body need today to start to become a little more stable so that then I can do other things with them? Because as you know, the frustration now a lot of our patients have with all these chronic illness things is they'll go to people who know these things and have some good training, but they'll maybe shoot a little too high in the beginning or shoot a little too low, which we all do. But because that's what worked before, which is human nature, we try and do it the same every time, right? But if you take somebody with, for example, mast cell disorder and some hormonal imbalance and some environmental toxicities and a few other things, each person could look exactly the same with their symptoms, but the individual will need one set of treatment to balance out, part A of, let's say it's the hormonal things, before they're strong enough to go after the other stuff. Other people will need a real gentle approach where you're just basically making them a little bit less toxic so that their body settles down. Then you can figure out who to jump into next there. And then some people are strong enough but out of balance enough where they can handle, accessing everything at once, sort of in baby steps. A little bit of hormonal balance, a little bit of get the toxins a little bit lower, work on the histamine response and all the other things. So I think it just came by necessity and not wanting to ever tell a patient, gee, I can't help you, I'm sure there's people I have not helped, I'm sure, in all those years. But combining the fact with I don't want to put you in a position as a patient where I can't do something for you, and then realizing just because I had success with that type of patient yesterday doesn't mean I'm going to have the same, pathway to success today. So I have to always be a learner, always be patient, but also be assertive enough with the case that I don't just let it sit there, Yeah. Because you can have people who don't feel well, but you're not sure what chess pieces to move next. And if you don't move any chess pieces, they still don't feel well. So that's a meandering discussion, but basically that's where it came from.
There's and all of it was beautiful, and I really appreciate you articulating it, because it's one of those things you just do, and how often you really think about how you got to be where you are in the way you practice. But there was one part you brought up, and I don't want to miss it. Everything was good, but when you said that when a patient comes into the clinic, instead of blaming the patient for what they have, maybe I can figure this out a little further and spend a little more time understanding it. And that's something that people experience, and I want to say that that's the most rare thing, I think, in medicine. That's not normal for a doctor to say, let me try and figure this out. It's on me to help figure this out. Because maybe it is in your head, something neurological, but I'm the one who needs to understand how it got to be in your head.
Right.
And to be your person. And so with that accountability part, was that ever modeled to you, or is that something that you just said, this is what's right and this is what's not right, and I'm going to do this the right way? Because that to me is the epitome of what's the right thing as a care provider, is not to blame the patient for being sick.
Right.
I mean, you blame the kid for climbing the tree and falling out and break their arm. You should not have been climbing the tree, son. But
Right.
Right.
I think it was modeled to me in snippets on different levels. For example, one of my mentors, I would say, modeled a very positive aspect of what you just mentioned, and also was the epitome of the negative aspect of it. So it was this real, real duality in one person. And the duality was they were probably one of the most, caring and reassuring physicians I'd ever worked with. And before they would do anything, even if they thought the person was making everything up or whatever, before they did anything, they would listen and they would collect information. But then the next thing that they would do, even if it all went badly after this, the next thing they would do would actually be to reassure the patient. And they would say, well, these things you're talking about, we should look into. These other things are actually kind of normal with what you've got going on, and maybe if there's something wrong over here, those will get better. But you're not going to die. You don't have cancer, whatever it is. So they were really good at that part. But they also would reach a point where, if it was outside the realm of their understanding, they would sort of tip over to the other side and just think, and sometimes say, this, you don't have anything wrong with you. This is all in your head. And, one thing I learned really early was you learn probably more from examples of things you don't want to repeat in your life. Yeah. I learned a lot about compassion and that stuff from the one side. But I also would just watch silently and think, I don't want to do that to somebody. I don't want to just tell them there's nothing wrong with you. It's and I've done this with enough thousands of people to know that there's always something. It might not be real obvious in the normal sort of medical rubric of, going through and looking for disease or whatever. But if people feel a certain way, even if there's a huge mental emotional component, there is also a physical reason usually that drives that. And it's because we're not disconnected there. If you think about it, if you've been told that you're crazy or that you don't have whatever disease you have or your symptoms mean nothing, that will make you have any neuroses you want to think of, and most of us have a few to start with. And so if somebody keeps, gaslighting us and piling that stuff on top of us, we're just going to get more anxious or depressed or whatever. So it's not like, oh, well, it's all in your head. It's like you have this, no one has helped you. And that is one of the best ways to torture somebody, is to keep them in this suspended animation of they know there's something wrong and you just keep telling them there's nothing wrong.
Yeah.
Right. So I think that, and I'm kind of, there's other people I could talk about that I learned other things from, but I think that duality, I saw, this part's really good, this, reassuring and saying, well, scientifically we can see this and this might go, But then the other side of, no, this is outside of my realm of understanding. They wouldn't say that out loud. But that's when your nuts would come out, or your whatever, you fill in the blank. And I think I just made a very conscious decision at that point to say, okay, when it gets to that point, I'm going to take this good part about being reassuring, and I'm going to say, is there some way I can dig into what's going on, like labs or some other thing, or just get into your history more, or whatever it is. And then, in my own practice, those were the kind of patients that came in, and the first thing you learn is it's 10 times harder than you thought it was going to be. Right. It's like, every now and then you get one that's like, just hit it right out of the park.
I love them. Favorite.
It's like, oh, that's not going to happen again.
Yeah. No.
Oh. But the rest of them, it's like, oh man, I have to think about this. I have to actually learn. I have to kind of go back to square one. So that's kind of the origin story for it. And there's just a lot of, when I think of the first 2 years I was in practice, those patients must have been, they were a very hardy group. because they wouldn't give up on me. They knew I could get an answer, but it wasn't going to be quick. Like they would come back and they would say, "We don't have it yet."
But they came back.
And they came, but they would come back
earnest.
because they knew that I would try something. I would look into it more or whatever. Or I had one famous case where, at least in my mind, it'll never leave my mind, where the husband of a woman I was treating for some hormonal imbalances, and back in the day, we weren't terribly aware of a lot of that stuff. He came into a follow-up visit, so I knew it was either really good or really bad. And he goes, "She tells me everything," and we'd sort of been on this little journey, and we'd made a few baby steps. And at the end, he looks at me, and goes, "I just want to tell you, you've really, really messed my wife's hormones up, and she's just not feeling good." And I was like, I know, and we're gonna get to the other side of this. It's like I was in practice like 3 months.
It's humbling.
And it was just like, I need to learn something here. And as whatever would have it, this is before the internet. I got a flyer, and there was this integrative endocrine conference, and it was coming up like 3 weeks later, 2 days, and I was like, I must go to this, because it's like, obviously there's gaps. So I would do that. And then, you get beyond that, and then the next 5 are not a problem. And then the next thing is, some other part of medicine, and you have to step back and say, gee, I don't know enough about that. I need to dive in. So it's that, and you just keep doing that. And the only, this may not make young doctors very happy, but now my practice is only people who are very kind of at the edges of the bell curve of unusualness, either with cancer or chronic illness. And I believe that they only are my patients so that they can humble me every single day to show me I don't know everything.
Yeah.
Now they believe I'm helping them, just for the record, and I'm doing the best I can. But the level of just general sickness in people and chronic illness that people have is exponentially worse than it was 30 years ago. Just because of a zillion things. So anyway, that's why I do what I do.
What you've just beautifully elocuted brings me to what I wanted to take a minute midway through our interview and then do more of like an introduction of you. And the reason why I'm doing that is because you ever do somewhere where the people, they introduce you to a speak at a conference, or you do an interview, and they always give you their bio up front, and it's not in context, and then you speak and things. I was hoping to weave your bio into this, and this is the moment I was going to weave it in here, but we're at the end of like the first part of this multi-part interview. I think it'll be 2 parts. 2 parts, I'm hoping, maybe 3 if I'm lucky. 2 parts definitely, because we're going to finish now. So we're going to come back, and we will have another episode on this to conclude our interview with Dr. Paul Anderson. This is wonderful sitting down with you. And again, we talk a lot, but I've never really asked you these questions, and it's great to hear you talk about this. And I'm really looking forward to our next episode. So we will have this put up, and then we'll have another episode next week where we'll do the conclusion of this interview with Dr. Paul Anderson. Thank you so much for tuning in. Again, if you find this material beneficial, please like, share, and subscribe. And I hope to see you next time.